All right. Well, thanks. That's thanks for that introduction, Amy. I appreciate it, and thanks for the opportunity to contribute to your great meeting. Can everybody hear me? Okay.
Yes.
Okay. Wonderful. Okay. So I think as a preface, let me see if I can get this PowerPoint up here. I want to particularly talk about and walk through some processes that we had put in place in my experience when I was in upstate New York. At the University of Rochester, particularly that were related to hastening our treatment times and our door in, door out times. And I'll explain why that was particularly pertinent. Right. And then the COVID conversation is one heck of a moving target. And so I think I'm actually be interested to know where you all are at. I will tell you kind of where we've evolved our practice here when we consider COVID with stroke. It's kind of, honestly, there's a lot of questions around it, I think, and there's a lot less to say, I think, overall, but I'd be interested more in where the conversations have been that you all have been part of, and I can provide some more insight into where some of our thoughts and considerations have been. So, all right.
For sharing, oh, there you go.
All right, everybody can see that? You guys got it? Okay, so, as a disclaimer, again, I'm originally an emergency physician who wandered into the acute neurologic subspecialties. And that was partially due to the infectiousness of the program at the University of Cincinnati. I think you probably all being Kentucky are familiar how really from the initial efforts to create an acute stroke team in Cincinnati, it was an endeavor that combined neurology with emergency medicine. So for me, coming through the emergency medicine pipeline, I had many of my mentors and faculty and people who trained me were part of the Cincinnati stroke team, or were some of the initial emergency physicians to be trained in neurocritical care. And I'm just fortunate to have some degree of some people who were already trailblazing some of those paths. My experience has been that a lot of places I've been that don't have as many emergency physicians who are versed in stroke and neurocritical care seem to be very interested in having somebody who has these combined experiences and skill sets to help with systems of care type stuff. They kind of almost talk to me like I'm trilingual or something. Like, I know, oh, you know how to speak EMS and you know how to speak emergency physician. And so usually I say we all speak English. I mean, but I understand their point is that there's just different cultures and perspectives in each one of those areas. And over the past 7-8 years, I just found myself kind of wading into those waters, and it's been a very rewarding experience, because I'm sure, as you all find as people who work with systems of care, pretty much everybody wants to do a good job. It's just helping everybody to communicate and talk in a way that kind of gets some things done. So again, I'm going to describe some of the background information that led to some of the changes. Some of the stuff I think you guys might be familiar with, the science behind the importance of treatment times, and then some of the results that we had in upstate that that I've begun to also work on in the Southwest Ohio region, and I'm looking forward to working with Amy even more so now that she'll be joining us in 4 days with TriHealth. So these are the objectives overall of what I wanted to cover. Again, I'm sure you guys are familiar with some of the relationship with treatment times, and then just some of the things that exist with how we can hasten some of these times. And again, particularly speaking to our experience in upstate New York. I do want to talk about this because I find that most of the talks on treatment times, they kind of jump to this paper by Jeff Saver, kind of talking about the rate at which neurons are lost in stroke. And to me, that this a little, sometimes this concerns me a little bit, because when I start talking to some pre-hospital providers, they kind of say, yes, this number is big. but what does this even really mean? And oh, well, geez, do I really need to put the sirens on my vehicle to save a couple of minutes? Does that even matter? And so, for me, I try to pivot the conversation to say, look, the thing is that the rate of loss of neurons in the setting of an acute vessel occlusion can be extremely quick for some and slower for others. And the bottom line is, from the pre-hospital standpoint, you don't know who is even more sensitive to time than others. And the thing that's also kind of, to me, lost in some of these data is that, the location of the stroke, as you all know, is so critical to their outcome. So somebody can have a lacunar stroke that takes up, less than half of a percentage of the total brain volume, but it's extremely disabling. And if you were to try to impress people with the number of neurons lost in a stroke like that, it's gonna fall on deaf ears. Particularly when the data that he used to generate this, as it says, it's of a typical large vessel supratentorial acute ischemic stroke. And you don't need to lose this many neurons or lose them this quickly in order to have an extremely disabling stroke. And so, and this is kind of a little bit of that analogy. Like, if you were to say, hey, if it rained 7 inches of rain on Monday, are you going to tell people that it rained 1 inch per day over the course of the week? Or are you going to say that, it rained 7 inches in 2 hours on Monday? And so it's sort of something that I think is, but I think that particularly as I've had more and more conversations with EMS providers, that it's just sort of something that I found I want to have caution with when trying to inspire some of our people who are trying to balance 100 different kinds of emergencies with some of the punchlines. And so I try to change that punchline over a little bit. And again, but I think that this graph, this is from Greg Albers, that was done after the Diffuse 3 trial. They kind of illustrated that one stroke is one stroke, that many different strokes have different time frames of the rapidity of the deterioration afterwards. And this is part of the reason why, as soon as you identify somebody who's having new onset neurologic symptoms, that you have to move quickly, is you just don't know who's even more sensitive to time than others. And so, really, to make a difference with some of these patients in this red bucket, we have to be moving quickly. And again, this is that concept around penumbra, which I'm sure that you all are well versed in at this point. Is that, at the moment that a stroke strikes, like that, this area of irreversible damage infarct, we have such a short period of time. This gray circle in the middle, we have such a short period of time to get that vessel opened if we're going to prevent that from being permanent. And that many of the late window stuff, yes, it's great that we identified that this penumbra, this green, this yellow circle, is an area that we know that will eventually die if not reperfused, and we have some time. But it's really the hastened treatment is to see if we can get that gray circle as small as possible. And again, that's where our time is so short. And this is often even the challenging question when somebody comes into the ED, much like when we return from vacation and we find a wilting plant. We don't really know if that plant is rescuable or not, but oftentimes we try to put some water back on it and see if it becomes revibrant again. And again, this is a lot of the theories around stroke is, unless I can tell that plant is definitely dead, I would like to start watering it and see if it can come back. And that's the analogy a lot of times I use with the brain. So again, this is like usually what how I like to think about an acute ischemic stroke is, brain cells, bottom line, brain cells die really fast without blood flow. And there are some strokes where there's some blood flow, and that blood flow is low enough where the function, where that part of the brain can't function, but it's not going to die quickly. And those are some of our late window strokes where there's still an opportunity to treat them. But we have to make the assumption that as soon as somebody has a loss of neurologic symptoms that could be related to an ischemic stroke, that we have a very short time frame, because by and large, brain dies extremely fast whenever a blood vessel is obstructed. And I'm sure you guys are all familiar with these data, and these are the data that I found to be really, really persuasive in the importance for treatment times and working with systems of care to optimize treatment times. Are that really, I mean, a 15-minute increment in savings, treating somebody just 15 minutes faster leads to reduced in-hospital mortality, reduced symptomatic ICH when giving thrombolytics, an increased chance that they'll have independent ambulation, and increased possibility of being discharged to home. When you look at a lot of systems of care where the median treatment times are still in that 45-minute to 60-minute range, or even low 60s. And we know that we have data that we can treat people within 25 minutes. We're talking about two 15-minute intervals that can be two 15-minute increments of time that can be saved, with efficient systems of care, leading to really truly tangible outcomes that make a difference to patients. And this is much as true with endovascular treatment as well. This is a composite of the data from the endovascular treatment trials, where you see that actually the patients who got treated within 60 to 90 minutes of arrival to the emergency department, that they had about an 80% chance of having a good outcome. But in patients who have a delay, and this is particularly important for our interhospital transfer patients, if they reach that, let's say if they arrive at one hospital and they get transferred to a different hospital to get a thrombectomy, and now you're at the 2.5, 3 hour mark, well, geez, you're just taking them from like a 80% chance down to a 60 or even 50% chance of having a good outcome. What a dramatic difference can exist. And so these data particularly is where I'm very passionate about the door in, door out approaches, because there are so many cogs in that wheel that need to be working together in order to get that patient identified and out of those initial hospitals that can't do the thrombectomy to a hospital that can do a thrombectomy. And this is particularly important because, as we know, these are our most disabling subforms of strokes, these large vessel occlusions. So this is what particularly motivated us to put a lot of time and effort into some of the things we did in upstate New York that I'll describe shortly. So door to needle strategies, I don't want to spend too much time because I think that you guys are the people who are usually teaching this to people. So obviously, that target phase 2 became target 3. And I know locally I've been harping on this 30-minute median time here. So this is really more what I wanted to be more of our primary goal is yes, we want to get 85% of our patients treated within 60 minutes, but we really want to really have our median times get below 30 minutes for all of our patients. Again, you all are familiar with these best stroke tactics and whatnot. So I'm not going to belabor this. You all are familiar with the fact that particularly we can forego labs. I find myself frequently educating people that labs aren't necessary unless there's some kind of pre-existing condition that would call for them. What I do want to focus on are some of these really highly successful door-to-needle strategies. And this is what I think are some of the most challenging strategies to implement, but they're overall high yield. I'm sure that many of you folks have been part of lean processes where you kind of take your 4 quadrants and you look at what are the low resource, high energy things, and low resource, low energy things, and high resource, high impact things, and low impact, high resource things. And some of these things are high resource or high energy requirements to do it, but they have quite a bit of impact. And I'll show you in the end really how putting particularly some of these into places and some of the workflows made a big difference for us. So, and that's having the patient registered and to really begin to dig into their medical history and the history of their stroke prior to even getting in the emergency department. This is an opportunity for us in Southwest Ohio. This is not routinely done. EMS gives pre-notification. They give us a heads up. They're oftentimes registered, but an opportunity that we have in Southwest Ohio, and I don't know how it is in Kentucky, is for us to move towards that culture of, okay, the patient's not even here yet, but let me sit down, open up a chart, enter orders, look through all their history. What do I know about their past medical history? What do I know about their previous stroke history, their neurologic baseline? And then an even more ideal situation is that you actually don't close that communication with EMS when they make that pre-notification call. That EMS can stay on the line and begin to talk with who your acute stroke responder is. And you can ask more detailed questions of EMS while they're on their way in. Is family with them? Particularly educating EMS on grab a cell phone number if you're not transporting the family or a witness of the event with you. And then you can make that phone call before the patient's even in your emergency department. And so really that the ultimate goal is that when the patient arrives in the emergency department, you're getting an examination to confirm that they are having stroke symptoms, and that you're proceeding to the CT table, and that as soon as you get that non-contrast head CT, you've gotten the history, you've confirmed but with your examiner that they're having a disabling stroke, you'll know that you can treat them at the conclusion of your non-contrast head CT with alteplase. And so I find that a lot of systems are not getting the majority or asking a lot of the questions that need to be asked in order to determine alteplase eligibility until once they're in the emergency department. And the pre-notification process helps. It gets people ready. It gets people to clear a CT scanner. But using that time also to ask more questions is where the impact comes. And so again, I'm sure you guys are familiar with this study. This was from Scandinavia and their journey of getting their door to needle times down to a median time of 20 minutes. You know, and this is where you see that some of their substantial gains here. Can you guys see my arrow when I use it? Yeah, okay. So I mean, when you see like some of these particular steep drops when they really took their door to needle times here from 60 minutes and they got it down here closer to 30 minutes. This was in the same time when they began to do a lot more of these efforts to begin to get that pre-hospital notifications. You see in 2005 when they began to do the statewide electronic records and getting the interview while they're in transport, that you see that dramatic drop there in their door to needle times, and it was kind of sustained there. And there wasn't, as you see from 2005 to 2011, they went from about 30 minutes to about 20 minutes with getting a little bit more refined with that. But you see that big drop from about 60 minutes down to 30 minutes was with implementing some of those measures. And this is exactly what they described in their discussion of their own paper, where they talked about the importance of trying to implement these strategies of really bringing EMS into the discussion prior to arrival and getting more information from EMS by keeping that communication line open. Now, the additional layer of this is that a lot of places, the culture is, and this is a culture that was in upstate New York there too, where the emergency physicians did not really feel empowered to make that TPA decision. And that they oftentimes felt that they had to wait for somebody from their stroke team to give them a green light on that. And so there's been a deluge of papers over the past, particularly 1 to 2 years, that have looked at, well, can we do more to help emergency physicians feel more comfortable with making these decisions, or guiding some of the questions that we need to ask to tease through some of the, particularly the relative contraindications. And you see, this is one paper that looked at implementing such a program where they gave some of the emergency physicians some focused training, empowered them further, and their median treatment times went from 54 minutes down to 20 minutes, really just with empowering the emergency physicians more. And then this is what some of the details of what they did. This is about 80 contact hours total of training, where they had them actually work in the neurology ward for a little bit, get a little more comfortable with their neuro exams, doing some theoretical teaching and practical things of, okay, here's a hypothetical case, how do you handle this? And then these are some of the some of that practical stuff of working with an electronic medical record before the patient even arrives, and then getting some neuroradiology training as well, getting a little more comfortable looking at the CT scan. What are we looking for? What's concerning to us? When do I want to, as the CT scan comes across, which findings I want to pick up the phone and call my radiologist right away and discuss it with them, see if I can hasten some of the radiology interpretations when there's any kind of concerning findings in the head CT. Again, this is again looking at some of the workflows from a different paper about where they achieved median treatment times in the 20-minute range, which are, again, it's at getting that patient history before arrival is a common theme in many of these systems of care who have done this. This was another paper that came out of New Jersey, again, empowering emergency physicians by giving them a focused neuroscience training that, again, in this case, it was about 96 total contact hours. And you see that their median door to needle times went from 83 minutes down to 35 minutes. So again, I mean, my disclaimer, as I said from the beginning, is that I am an emergency physician. So you're probably not surprised to see me advocating for emergency medicine's role in hastening these things. But to me, that is the key. I mean, the key is really just doing things in parallel and doing things sooner, and empowering people who are on those front lines to do those things. I think it's always critical to have somebody who has stroke expertise available at all times immediately to help you with decision making. I think for me, again, being in the back end, I'm doing fellowship training, doing telestroke myself. oftentimes really what I'm trying to drill down to is, can I help them with those difficult cases? Yes, we have a relative contraindication to alteplase here. Let's counsel the family or the patient this way about that. But a slam dunk 3-hour treat with no contraindications, this is something where we want to make sure that our frontline providers are comfortable with identifying and doing, and that they don't need to have a TPA gatekeeper that's getting in the way, or they're waiting to give them permission to do something that they shouldn't feel hesitant to do. So I think that's where driving towards a harmonious system of bringing that specialty input in, but empowering our EMS and emergency department providers will achieve the best treatment times for our patients. So this door in, door out concept is even more complicated, right? Because this is not just a patient arrives in your emergency department and you need to think about a TPA decision. This is where you got a patient in another place who needs to be identified. You need to get transport arranged, and then you need to get them to your facility into your thrombectomy suite to actually do the procedure. And when you look at this, if you were ever actually to add up the number of people who need to do something and take care of one of these patients in the first 2 to 3 hours of care, it's like 120 to 180 people. From the people who your initial 911 dispatchers, to your EMS personnel, to the nurses, CT techs, radiologists, emergency physicians at the lab at the initial hospital, to the transport communication center, the transport team, and then at the receiving center, usually your neuroscience people involved, your emergency departments involved, your thrombectomy techs, your nurses, your proceduralists, and then your intensive care people who are receiving the patient thereafter. I mean, and your transfer center at your receiving hospital. So it's a tremendous number of people who need to be doing something in this process. Sometimes it's almost like amazing when you get a really quick treat from a transfer about how all those people come together to make that happen. Again, we talked about before about the importance of treatment times. This is another analysis looking at both the early and the late window data about how treating patients makes such a difference. So this is an approach where we don't really want to just identify the patients who present in the 6-hour window, which is the Hermes data. We want to not miss any of these patients who have a large vessel occlusion who are eligible in treatment in the early or late window patients. So in order for us to try to make sure in upstate New York, so I should jump into this slide real quick. So where we were in upstate New York, we had a very large geographical swath to deal with. So this is where Rochester sits in upstate New York. The only other there is one other comprehensive stroke center which sits right here. Or I'm sorry, I think they're thrombectomy capable. I don't know if they're comprehensive yet, which sits up here a little closer to. This is Lake Ontario up here. The other one is over here in Buffalo. And the other one is over here in Syracuse. But from Rochester all the way down to Pittsburgh, which is probably right about here, and then there's Danville, which is like over here. There's no other center that does thrombectomies in this whole area. So it's a huge area of referrals that we need to identify patients. So our farthest facility away, which was down here in Elmira, New York, is about 2 hours and 20 minutes by ground. Elmira is a reasonable sized small town in the southern tier of New York. Ithaca also sits over here, which is a college town. That's where Cornell is. Ithaca College. It's a reasonably populated small town in upstate New York. And then there's a bunch of other towns, which again, they're kind of smallish type towns. Geneva is over here, over here. Another one called Horseheads. And there's several other little even smaller towns that all are populated all amongst this area. So our closest hospital for referrals was actually here, and this map isn't really to scale. This actually was 45 minutes away from University of Rochester. So we really deal with most hospitals that by ground were between 45 minutes and 2 hours and 20 minutes away by ground. So we really had to do things to get them out of the emergency department as quickly as possible, particularly if things weren't flyable. And so I want to go back here when we were trying to think about how we could really leverage our system. Ryan McTaggart and his group in Rhode Island, they had published some data about what they had done in the state of Rhode Island to try to hasten treatment times. And their overall the components of their system of care were in their non-thrombectomy performing centers. They would notify the CSC on arrival of any suspicious stroke patient for the large vessel occlusion. They would perform a CT A of the head and neck immediately on arrival, so it'd be done within 30 minutes. And they would have their images automatically pushed into their cloud-based imaging platform, so that the people at the CSC could review it. And they found that when all of those elements were achieved, patients were treated much faster, and that they had twice the chance of a good outcome when all the elements of the protocol were missed. So obviously doing these things treated patients faster, and not only did it treat them faster, it also their observation was that patients had a much better outcome. So again, the challenge for us was that you could fit all of Rhode Island into Monroe County, where the county seat for Rochester. The entire state of Rhode Island fits in that one county in upstate New York. So we're dealing with, again, with a much bigger area, 14 more counties. Monroe County itself is actually bigger than Rhode Island. So we're particularly really focused on how can we use a helicopter as often as possible, and how can we get the helicopter there as often as possible. Now, the additional challenge was we didn't want to start transferring every single person who looked like they had a stroke in upstate New York to Rochester. As you mentioned, as I'm sure it exists in Kentucky and it exists in Cincinnati, many of the people who even live 45 minutes away from the University of Rochester, they don't want to come into the city of Rochester. They prefer to get their care locally whenever possible. So there's really no advantage to bringing patients up to Rochester who don't need it. And if anything, it's extremely disturbing to them. Their families have had a sudden event that's very stressful as it is, to have to now come up into the unfamiliar urban environment is just it's just even more unnerving for them. So we wanted to make sure we weren't unnecessarily transferring patients either. So this was the pathway we put together. And again, these are the principles based upon everything I've shared. We want to make sure that all acute ischemic strokes who met AHA guideline criteria for endovascular treatment would be identified promptly within our region. We basically no LVO left behind, as we all say. We wanted every patient who could stay at the local hospital to stay at the local hospital. We wanted to minimize unnecessary transfers. We wanted to get our median dido times down to 60 minutes. This is before we were putting this process together in 2017, and this is before the AHA had gotten involved and given a standard. As we developed this process where the AHA we were talking about this, and they were talking about maybe 120 minutes for didos or 90 minutes. We had said we want our median times to be less than 60 minutes. And we wanted to have our median outside hospital to groin puncture times to be 120 minutes. So as you imagine, this is also pretty ambitious. So what this would look like is somebody would come into the outside hospital, they identify as being an LVO. Hopefully their dido would be about 45 to 50 minutes. Their transport by helicopter would be 30 to 40 minutes, which means that they would arrive at our hospital about 90 minutes in. So they would go directly to our angio suite, and then they would get their groin puncture time within 30 minutes of arrival to our facility. Our qualifying criteria, the patients that we wanted to identify, were any patients who had an NIH stroke scale score of at least 6, who on their non-contrast head CT, they had an aspect score of at least 6, and that they had an anterior circulation large vessel occlusion. Again, these were the AHA guidelines at the time. I presume that most of you are familiar with the aspect score, just as a reminder or a refresher for those who kind of gets a little more vague with, who haven't heard of it yet. So the aspect score is a way of assigning a score of 0 to 10 to describe the amount of already lost or tissue in the brain that's already begun to suffer early ischemic changes. So a score of 10 out of 10 means that there's no early ischemic changes and that presumably the entire MCA territory is still salvageable. A score of 0 means that your entire MCA territory is currently already suffering ischemic changes that can be seen on your head CT, and it's much less likely to be salvageable tissue, and it can't be saved. So again, a score of 6 or greater suggests that at least 2/3 of the MCA territory is still salvageable. And there's overall characterized as having really 4 quote unquote subcortical areas, which are your caudate head, your basal ganglia, also known as your lentiform nucleus, your internal capsule between your thalamus and your lentiform nucleus, and your insula are kind of viewed to be the subcortical areas, with the more cortical areas being your M1, M2, M3, M4, M5, M6, going from the cut at about your 3rd ventricle up to your more superiorly towards your lateral ventricles to overall assign that. Now, interestingly, as you guys can see here, I'm sure you guys have seen this history, but this score is actually described in 2000 in Lancet. It's a pretty old score. And part of the reason for using these two cuts is this is back in the day when CT scanners were like at least an inch thick in their cuts. We didn't have these 2.5 millimeter or even like 0.8 millimeter cuts that we have now. That's part of the reason for using these two sections, was we're just kind of going up a centimeter in the MCA territory. So what was a workflow that we were using to identify the LVO patients? Again, somebody arrived to the outside hospital with stroke-like symptoms less than 24 hours. We had them at the gate getting a quick NIH stroke scale score. We wanted to emphasize to the region that we didn't want this extremely precise score where people were nitpicking and making sure that they didn't score like a 14 instead of a 15. Our bottom line was get that score and is it greater than 6 or not? If it's greater than 6, you definitely have somebody who's got a disabling stroke, and you've got somebody who's now, if they have an LVO, they're going to meet criteria for treatment if they don't have a lot of early ischemic changes. So these patients, one of them, when they go for their non-contrast head CT, they get a CTA of the head and neck at the same time. And we asked all of those hospitals, which were a total of 22 referral hospitals, to set up a process where whenever they did these images, it was automatically pushed into that cloud imaging viewer. And the imaging viewer we're using at the time was called Life Image. I think we switched over to PowerShare, I think it was called, after like a year or so of doing this project, but we were using Life Image at the time, which was a common cloud imaging viewer used in the Northeast. Now, if the NIH stroke scale score is at least 10, this is where we began to mobilize things right away. This is where I think it got interesting and even a little sometimes controversial for conversations. So if when the person got into the emergency department and there were NIH stroke scale score of 10, this is where we had them auto launch transport. So I had them just call their helicopter provider and say, send a helicopter to us. We have what really the words that we taught all of our helicopter providers was code LVO. And then so we said at the outside hospital, call our transfer center at University of Rochester and say, we have a code LVO, and then send us the demographics of the University of Rochester. So we can begin to register the patient in our system, and then call your local transport provider requesting a helicopter first. And if the helicopters, if you're not flyable, get a ground crew coming at you right away and proceed with your TPA evaluation. So it was just these 6 to 9s where we said we don't want to mobilize your transport team for the 6 to 9s, but if they're 10, we did. And the reason for using 10 as the cutoff was that at 10, your pre-test probability for having a large vessel occlusion is about 60 to 65%. Now, if you add on the hemorrhages that couldn't stay there, that oftentimes also are of that residual 30 to 35%, we anticipated that 70 to 80% of the patients with an NIH stroke scale score of 10 on arrival would end up needing to be transferred up to the University of Rochester from all these centers, which were a combination of primary and acute stroke ready centers. Overall, and the agreement that we had with all of these transport crews was that they knew that they might be stood down. So we told them that you may get there, and we're going to determine that the patient does not need to be transported, and that you won't actually transport the patient. And they were fortunately all agreeable to that workflow. Now, again, once we got that call that we had a code LVO, again, the code for us at University of Rochester is that if we got a code LVO notification when we were on acute stroke call, that we knew that meant that there's some patient at one of these referral hospitals that has an NIH stroke scale score of at least 10 with imaging pending. So that would mean that I would then get to a computer, I'd log in to our cloud imaging viewer to look at the images as they came across right away to help screen for the presence of an LVO and an aspect score and or a hemorrhage, and then call back through our transfer center to that referring hospital to help relay to them is that, hey, we've got, yes, you do or do not have an LVO or whatever it is. And then we could provide advice if the case needed to stay there, or jump on a telestroke evaluation if we needed to do that. Or we could say, hey, look, you got an M1 occlusion, your aspect score is good. We need to move forward with transport. What else can we do to help finish the TPA evaluation if you're doing that? We had educated folks on a succinct set of data that we were collecting for the patient-related information, which we had a defined note that we're putting into our EMR we're using was Epic, so that would have the pertinent information that everybody would want, who's going to be taking care of the patient once they arrive to the University of Rochester. And so this is the information we're asking. Was we wanted to just have a quick note that said their NIH stroke scale score, if they're coming by ground or air, if they were on any anticoagulants, and then an INR if they were on Coumadin. Did they get TPA? What was their last known well time? Family contact name and phone number, and then their baseline functional status. What we had moved towards even was creating stickers where if the nurse collected this stuff, they could just take a sticker and then put it on the patient. And then whenever the patient went through everywhere, all of this information was just on their hospital gown. We could just, no matter what, you didn't have to log into the EMR even to do it. Everybody could see this information wherever the patient went. So on our end, what we did was once the outside hospital nurse from their emergency department or even inpatient nurse, this was an inpatient stroke, if they gave a report to us at University of Rochester, we would then send a page out, which would now be the page to activate all of our teams. Because at this point, we now know the actual ETA of the patient. And this is again so that the patient can come once they got to the University of Rochester, they can go straight into our thrombectomy suite. And so here's some of the early results of this. So of it. So we had particularly pushed it out to our 3 highest volume centers. These were the hospitals that were in Elmira, Ithaca, and Geneva, New York, which were the largest populated towns in there. And you see that before we did this product, our median dido times were between 2 hours and 7 minutes and 2 hours and 17 minutes. And you see, by doing this process, one center got their median dido times below that mark of 60 minutes. So they were median times were 57 minutes. The longest was still 1 hour and 43 minutes, but it was still about 24 minutes faster. So overall, the median times went from an aggregate dido of 2 hours and 10 minutes down to 1 hour and 20 minutes. You see that we went from only 1.1% having a dido of less than 60 minutes to 15.4%. And you see that of our LVO transfers beforehand, only a quarter of them were getting a thrombectomy, and then afterwards, over 50% were. So we doubled the amount of patients who remained eligible for a thrombectomy. So this was a combination of better selecting patients for transfer, as well as transferring them faster so that they didn't expand their infarction and then become ineligible. And then also you saw that we saw a reduction in mortality rate by 10% as well with the initial rolling out of this process. And then this was, if you looked at our times in our region that we're doing code LVO versus New York State as a whole. So again, the over the same period of time that we were doing the code LVO process in the Rochester region, the rest of New York State had median dido times of 2 hours and 10 minutes, with 3.7% of them being less than 60 minutes, as again compared to the data that we had in the Rochester region for us. This is how the whole schematic looked, and this kind of goes back to my conversation before about the tremendous number of people who need to get involved with this. A lot of people teased me about this because they said it looked like it was the Krebs cycle. So like I'm like, yeah, it's like, so usually whenever we went to talk to the outside hospitals about this, we would not show them this first. This would be the last thing that we showed them because people kind of just like stop listening to us if we showed them that these are all the kind of the schematics of the process in order to accomplish it. We wanted to focus on trying to use more of these swim lanes so that people kind of understood the role of the different components. This is the transport role. This is the outside hospital role. The yellow was what we did at the CSC. And as you see in the bottom, Sarah Gallagher was our regional stroke coordinator at the University of Rochester. And so her and I had worked together on this, and she deserves a tremendous amount of credit for all of the work that was put into helping to educate and get buy-in across our region with all this stuff. Sarah was an emergency nurse who then became a QA nurse, and she also was a HEMS nurse. She was a critical care transport nurse before she moved into this role. So her and I had sort of some of the similar backgrounds and whatnot. So with the process. So again, a lot of people to acknowledge, like I said, this was a tremendous effort. And so, and it's still ongoing in upstate New York. So I'm hoping to continue to find time to work with them because they have been collecting data. We just haven't analyzed it about how it's been going since the end of 2018. I know that they had texted me since I had left the University of Rochester in July of 2019 to come back down here to Cincinnati in my role that I have with TriHealth. And that they had even gotten a dido time for an LVO of I think it was 27 minutes, which was pretty amazing. So and again, this isn't meant to be a hasty process where you just grab people and throw them into a transport vehicle just because they look like they have a stroke. It's sticking to those principles that I said of transporting patients who are most likely to benefit from treatment. Now, next thing I want to talk about quickly is mobile stroke units. To my knowledge, in Kentucky, you do not have any mobile stroke units as of yet. I have not heard of any programs moving towards it. I know it's even more complicated in Kentucky because you all are a CON state, which makes it oftentimes a little harder to just throw another $1.1 million ambulance into circulation into Kentucky. So I imagine you guys are all familiar with mobile stroke units at this point, though, or their potential role in systems of care. These are ambulances that can have either a 3 or 4 person staff. That staff is usually includes, if it's a 4-person staff, it's an EMT, a paramedic, a critical care nurse, and a CT tech. What they will do sometimes, they'll use a 3-person team where the CT tech is cross-trained as an EMT. So they become basically the driver of this. And then once they stop driving, they do the CT scan and back. So in back of this is a CT scanner, which can do non-contrast CTs of the head and CTAs of the head, and they're potentially perfusions. I only know of one program that's doing perfusions, and you have a telestroke platform in there, so you can have your acute stroke physician evaluating the patient, and many of them have also lab analyzers. Different programs run different extent to them. Some of them run CBCs, BMPs, of course, pot glucoses and point of care INRs. Other programs keep it simple and just have point of care INRs and finger sticks. So, but they have some degree of lab capabilities as well. Overall, these mobile stroke units, when they're put into circulation, they found that the overall treatment times are much faster when you look at this. So the black bar is the treatment before mobile stroke units, and then you see that the gray bar is the alarm to needle and then the door to needle times. So you see in all these circumstances, you're looking at about 25 to 40 minutes of treatment time savings. So again, going back to, as you guys already know, and I don't suspect I'd tell you guys anything on the 15-minute threshold of achieving tangible outcome differences for patients. But as you can see here, that when these units were implemented, there were tremendous time savings once they were implemented. And so also the most recent data is now showing that there's savings in the door to treatment time for large vessel occlusion patients by mobilizing if your MSU is well integrated in your system, you can mobilize your teams faster. And then additionally, you're also going to be able to triage patients, particularly if you have a CTA capability. You're gonna be able to identify those who have large vessel occlusions that need to be at a thrombectomy capable or a comprehensive center, and so you can actually improve your correct triage rate from about best case scenario is 70% using some of the pre-hospital stroke scales, like your CSTAT, RACE, VANS. I'm not sure what you all use in Kentucky. I saw your mouth move, Amy, but you're muted.
Sorry, Kentucky, the state protocol is CSTAT.
CSTAT, okay. Yeah, so if you look at optimal implementation of something like a CSTAT or a FAST-ED or whatever scale is you're probably triage about maybe 70% is best case scenario, but with the mobile stroke unit, you can triage patients 100% of the time correctly. So we in our circumstance, we had a lot of questions in Rochester when we rolled our unit out in Rochester, because because we were rolled out initially in the city, and so, is the proximity of the hospital. The question is, do these have more of a role in your bigger urban environments where things are more congested, or could they have a role in smaller cities like a Rochester, where there's about 1.2 million people in the metropolitan area, which might be similar to like a city, let's say like a Lexington, or even a Louisville is probably a little bigger than that, but something like that, where you have a bit more of a mid-sized city. And so this was a case that we treated in our emergency department at the University of Rochester. And you see that this is a case where everything went really fast and went right. This is a patient who their door to needle time of arriving to our emergency department to treatment time was 18 minutes. So obviously we treated them very, very quickly with our door to needle, and that their time from calling 911 to treatment was 46 minutes. So the alarm to treatment time for this patient was 46 minutes. Again, the alarm to treatment time, I think, is what's most important when you're comparing a mobile stroke unit to what you can do. So I think, again, I think it's hard to say you can do better than 18 minutes for a treatment time in the emergency department. Anybody disagree with that? Take silence as you all agree that 18 minutes is probably hard to consistently do better than. So when we compare that to, let's say, when our best treatment time on the mobile stroke unit, this is somebody who their alarm to treatment time in this case was the alarm came in at 9:07 and they were treated at 9:37. So in this case, the alarm to treatment time was 30 minutes. So you see in this case that the time from getting onto the MSU and getting treated, we treated them, their door to needle time was 9 minutes on the mobile stroke unit. And so the way we did this was, again, it's applying some of those similar principles that I mentioned earlier, which we applied to the MSU workflow. So this is a picture of somebody with a hands-free device. It's not our nurse, but what we did was on the MSU, we had our the critical care nurse on our mobile stroke unit wearing a hands-free device, and we had a cell phone assigned to the mobile stroke unit. So what happened was when they got dispatched to the scene, the nurse and the paramedic would go out and they would begin assessing the patient along with the other ALS unit that had responded. And so if the MSU was going out to assess the patient, like say if I was covering telestroke, I get the page MSU is going out, I would log into our MSU our MSU tele environment, and we were using something called Max Life, which allowed for conference calling. So on the cell phone being held by the MSU nurse, they were also called in to the Max Life platform. So I'm on the Max Life platform inside the mobile stroke unit. You're on the Max Life platform, and then the nurse is. And so inside the stroke unit, you have the CT tech who's doing the registration for the patient. And then you have the nurse who's now going out to wherever the patient is in the field to begin gathering information. So as the nurse is gathering that information, they're saying things out loud, and I can hear their conversation with local EMS, with the patient, with the witness to it. And at the same time, we're immediately getting the patient registered into the EMR before we're putting them on the mobile stroke unit. So I'm beginning to review their medical record. So in this process, I'm reviewing their medical record. Now I'm able to coach our nurse. Can you ask this question? Can you ask that question? Can you clarify this? Can you clarify that? Or I see they're on anticoagulation. Can you please ask them when was the last time I took their Eliquis? So I'm even before putting the patient on the ambulance, now I'm actually coaching the nurse or the paramedic to ask some questions that we need in order to determine TPA eligibility. And again, instead of us, a typical process right now from an EMS environment is you get a 911 call, ambulance get there, you put the patient on the ambulance, you start driving. Now you call the emergency department, and now you're registering the patient. And now at best case scenario, you're beginning to get some of the background information on TPA. With the mobile stroke unit, I'm now able to actually begin getting information on the patient before the patient's even on the ambulance. And so that's how we were able in this case to be able to, before the patient was even on the ambulance, in this workflow I mentioned here, in this case, I was able to actually know before the patient was even on the MSU that this person was a candidate for TPA. I just needed to see the non-contrast head CT to know that they didn't have a hemorrhage. And even in this case, actually, interestingly, just like 3 weeks before, he had inguinal hernia surgery, and I wasn't sure how his surgeon would feel about TPA. So I was able to look at his record, page his surgeon, and ask him, "Hey, your patient's having a stroke. It's pretty disabling. Are you okay with TPA?" And his literal answer back to me was, "Bombs away, man. Go for it." So I mean, it was super helpful to be able to get all this information before the patient was even on there and to treat them so quickly with TPA. And obviously he did very well. He went from an NIH stroke scale score of 14 to 0. He had a partially occlusive thrombus in his distal internal carotid artery that partially resolved with TPA, and then we treated him with heparin for a few days in the ICU, and then he left with no deficits. So anyway, that's the potential of a mobile stroke unit, if it's optimally, in our mind, based upon current knowledge, kind of optimally integrated within systems of care and times of treatment. So anyway, that's kind of my passion with some of the stroke systems of care stuff and some of the opportunities. I know Amy wanted me to comment a little bit on COVID. I think, a few months ago, obviously we were more preoccupied with trying to sort out a lot of this COVID stuff. and a lot of the workflows we would need to consider for it. I think, for us as a whole system of care, stroke, just like any other emergency, we've moved towards just having some of those standard precautions for all of our patients where, if everybody's wearing a mask and an eye protective wear when anybody comes in who's unknown, and then if you're doing anything that's remotely aerosolizing, then we're wearing our N95s or other masks as appropriate for more full PPE. Honestly, we haven't gotten more complicated than that. I will say that for our strokes, any stroke that I'm in, I'm getting a COVID test on all of them to screen for somebody who has asymptomatic or maybe minimally symptomatic COVID-19 infection. We in our system, I've only come across, to my knowledge, 2 patients who were found to be positive since March with COVID, who had a stroke. For one of them, at least, it didn't. I don't know that it actually was a cause of stroke. It was somebody who had a known thrombophilia, who was off of their anticoagulation, and had atrial fibrillation. So I don't know, he was pretty well set up even before COVID to have a stroke. So I don't know how much COVID increased his risk, but it could have. The other case it's possibility that it played a role. He had some risk factors and did it. Now, as an intensivist, I also work a little bit in a medical ICU, and we've had several of our COVID-19 severely sick patients have strokes, at least 3 of them, all ischemic strokes. As a result, 2 of them, they seem to kind of come overall out of nowhere. One of them, the patient had a 90% carotid stenosis, and he was being proned. So the question was, did actually all the proning with the turning and contorting of his neck, did that actually contribute to him having the stroke as opposed to the COVID itself? That's been our personal experience at TriHealth with some of our COVID cases. I think overall, I think we would try to avoid becoming too distracted or enamored by it. I think even earlier on, our other emergencies like STEMIs and whatnot, there was a lot of hemming and hawing. Oh, is this a COVID myocarditis instead of an MI? And I think we more tried to actually actively move away from any of those preoccupations and just use some standardized precautions based upon those assumptions, rather than having delays occur in assessment and treatment of possible stroke patients. So I'll stop talking and see if there's any questions or anything else I can talk about with y'all.
We do have questions. The first one was, let's see, how did you get AMR involved on the mobile stroke unit? As far as they knew that AMR, most of the mobile stroke units that they had heard of were privately owned.
Yeah, good question. So AMR was contracted with the city of Rochester. They provided EMS for the city of Rochester. So it was the funding for the unit was a combination of some philanthropy with some investment by the University of Rochester into the components on there. So philanthropy tried to help with funding the actual ambulance. We had to help pay for the CT scanner and the telemedicine equipment. And then the AMR actually operated the ambulance. Now, one of the reasons why actually working with your local EMS and having the mobile stroke unit be overall owned and operated by EMS is perhaps more advantageous than having it hospital owned and run, is that you can get away from some of those Stark law considerations that everybody's so paranoid about. I think you guys are all familiar with Stark laws, where basically if you can't give anybody the impression that you're giving EMS a kickback for referring patients to your practice, to your facility, or whatever it is. And one of the unfortunate things is that if your mobile stroke unit is operating as an ambulance, and let's say that you do co-respond with local ALS, that local ALS, they may go there and begin to assess the patient, and then they can't charge a bill. They can't get paid for those resources they invested or the run. And then even some programs have developed rendezvous programs, like Houston has been doing rendezvous for a while, where in their outer rim and more of their suburban areas and their rural areas, their local EMS may grab a stroke patient and start driving towards the urban environment or towards where the stroke centers are, and then the mobile stroke unit rendezvous with them at a site. And again, in those circumstances, if it becomes dicey about who actually gets to actually get the funds for the run. And so if your unit is hospital based and hospital run, and your hospital unit is because they provide the terminal transport to the hospital, if they drop the bill, excuse me, you can't do like a mutual aid agreement where you give some of that payment back to the original responding ALS group, who may have responded and begun the assessment, or responded and even begun to transport the patient to you, because it may look like a Stark law violation. If the unit is, particularly let's say with the AMR unit, we wanted to have it operate through all of Monroe County, and to do some of these rendezvous by being a city of Rochester vehicle, and the city of Rochester is getting all the funds for doing the transport, they can then establish traditional mutual aid agreements with all the surrounding EMS agencies. So let's say if you get $600 for doing an ALS run, and you establish a mutual aid agreement where you say, okay, let's say EMS agency Z goes out and they pick up a patient and begin to transport it, and they begin the assessment, and then your mobile stroke unit meets them. The mobile stroke unit does the final transport. They charge the patient. They get $600 for it. You can have a mutual aid agreement where like $150 or $200 goes back to the original responding unit because they responded. They used some resources. They may have started the IV, et cetera, whatever it is, for the patient when the mobile stroke unit was getting there. And so by having it operate with AMR and be city run, we're able to avoid some of that stickiness with is this looking like it's a hospital kickback to an EMS agency for a stroke patient. Does that make sense? Yes, you sure? It's really convoluted, actually. It's really complicated. Like, I mean, I'm sure many people who are involved with EMS, you're familiar with that. Like, there's a lot of mutual aid agreements, particularly out in suburban and rural areas. There's a lot of mutual aid agreements that exist for, let's say there's only one medic on who can do an RSI for like six different EMS territories, or you'll have one ALS unit that's covering 3 or 4 territories at night, and all the rest of them are just, they have BLS coverage. So in that setting, you'll have these mutual aid agreements where, yes, your BLS unit may initially respond, and then if the one ALS unit then responds from a different jurisdiction, there'll be a splitting of that ALS funds back to the original responding BLS unit, and then the rest goes to the ALS unit, if that makes sense. So it's a common practice in EMS. Sorry, go ahead, Amy.
Sorry, not to run you over. We do have a second question. She would like to know about door and door out protocols. I love the proactive prompt of the activation based on the NIH stroke scale of greater than 10. With all the emerging and validated LVO screens, would one of those be optimal to save time? And if not, why would the continuing with the NIH greater than 10 be optimal?
Gotcha. Yeah. So, I mean, from our point of view, whenever we're evaluating a stroke patient in the emergency department, we're doing an NIH stroke scale score no matter what. So because the workflows, at least we had in upstate New York, in all those settings, the nurse and the physician, particularly the nurse when they arrived, were doing an NIH stroke scale score. We didn't want to add an additional LVO scale on top of it for the nurses. So that's why we just said, okay, if your NIH gets above this cutoff, that's when you know it's an emergency. Now, if your region is really good about doing pre-hospital stroke scales, like I say, like again, with a CSTAT, and let's say you have a CSTAT of greater than 2, and let's say your EMS gives pre-notification to your primary stroke center that they're on their way in with somebody with a CSTAT of greater than 2, you could actually very reasonably use that as your way of also activating these protocols based upon the EMS notification. So you could always, I mean, that would be even faster, to be honest with you, if you did that. In upstate New York, there was not uniformity of using pre-hospital stroke scales. Pre-hospital stroke severity scales. Everybody was doing a pre-hospital stroke scale. Just there was not adoption of a stroke severity screen. If our EMS were doing that, we may have used that instead of using an NIH cutoff. Does that make sense? Does that answer the question? Yeah. Okay.
I have a question. As far as your inpatient strokes and COVID, did you guys do anything different or change any procedures with that, as far as would you treat versus not, or even just your procedure for doing it?
I mean, Overall, like I think our group here was pretty good about not getting too paranoid about when patients were coming in through the emergency department. So there wasn't any hesitation to the ones coming through the emergency department. In the inpatient environment, honestly, those were challenging identifications. All the patients who developed strokes were intubated, paralyzed, and being prone on mechanical ventilation. So it was very difficult to know when our last known normal time was, and to really know how abnormal their neuro exam was. Like, so oftentimes we would kind of pick up, maybe they're not moving their right arm as well, so can we even safely get them to imaging? So a lot of the things was, okay, yes, we would identify with one of our sedation holidays or whatnot, that there was some kind of neurologic asymmetry. But then the next question was, is this patient even transportable? Because depending upon how advanced their ventilator settings were, and can you even get them down? Very early on, it was hard to get a lot of diagnostics. The first like 3 to 4 weeks of COVID, everybody was so concerned about moving any COVID patients, particularly sick ones, and the implications on spreading COVID throughout the rest of the hospital. At this point, everybody's practiced and everybody's comfortable with moving anybody who's intubated, even with COVID, down to the MRI, CT suite, whatever it is. So we at this point, there's no difference in, once we identify somebody who's that sick with neurologic changes that could be a stroke, with getting the test. None of them were eligible for acute reperfusion therapies. One of them did undergo a decompressive suboccipital craniectomy because they had a large cerebellar infarction with cerebral edema. You're muted, Amy.
Sorry. In the chat, it says, please ask who is responsible for pre-registering the patient and initiating the order set once EMS called the ED. Who is the patient demographics being communicated to? Is it the RN or the registration clerk, or does the RN do like a quick reg?
So at each one of the hospitals, it was different. Some of them were using, we call them HUCs, health unit coordinators, who would answer the calls in some of the emergency departments. In some of those emergency departments, it was a charge nurse. In some of them, it was a RN who was always answering their calls. So it was different in all those settings. It was whoever would answer their EMS calls that would do that. At University of Rochester, we use a nurse who would receive all the calls from EMS. The second part of that question was?
Second, was it the
the order set? The order set was entered typically by the emergency physician or the stroke team, because they both were activated. A page would go out with we would use our stroke alert process to activate everyone. So when that page went out, typically our process at University of Rochester was that the stroke person would quickly talk with the emergency physician who was going to be getting the case, and then they would quickly say what they knew and then who was going to put the order in.
Okay, if you guys have any other questions, like I said, you can you can unmute yourself from your picture over on the side, or you can type it into the chat box, whichever one is easiest.
Good morning, Dr. Zammit. Hi, thank you for spending your morning with us and sharing your protocols and work. We surely appreciate it. I know early on with COVID, there was some concern about if you had somebody maybe convalescing at home, not the ICU patient in-house, but comes in, know they're COVID positive, stroke symptoms, and concerns about potentially administering thrombolytic therapy. Those seem to sort of have gone away with some limited data. I just wondered what your thoughts are on that. If you have somebody not acutely ill, but they come in with acute stroke symptoms, known COVID positive, how you think that might factor in on the decision-making for thrombolytic therapy.
I would treat that. My approach would be no different than if they were any other stroke patient. make me wary on what their thrombotic burden was in the rest of their body. So my subsequent post-thrombolytic treatment would be pretty aggressive, but for looking for other areas of thrombosis, like I'd probably get lower extremity Dopplers and a CT pulmonary angiogram on them to look for other areas of thrombosis that I might want to be aware of to better characterize their thrombotic burden at that time. But for me, it wouldn't change my TPA decision making at all acutely. Overall.
Thank you.
Yeah.
Chapman from Baptist Health Paducah said, well, they're starting to see post-COVID strokes, such as 3 to 4 weeks post-diagnosis in treating. Let's see, is this trending in other areas?
So I'm not sure yet. You know, I've heard some rumors from other colleagues. I haven't seen good data to say totally that yet. I know at least from our COVID patients we take care of in the hospital, particularly the sick ones, you know, they're we moved towards just screening for DVTs. You know, we didn't wait for like a swollen extremity. We were being proactive about looking for them to give us a reason to escalate them to fully therapeutic anticoagulation. I think you all have probably seen some of the data. There's, you know, some centers had moved towards putting patients on full dose anticoagulation. I think Yale and Mount Sinai were two of the most notorious ones for doing that. Empirically, some of the data that came out, I think it's a little plus or minus on whether or not that should be the practice. I think there's also questions about whether or not COVID patients, even at home, if they should be on prophylactic dosing. Last I saw, there were clinical trials looking at both of those questions. So I'm kind of right now, I'm more of a zone of equipoise on what to do to potentially prevent these things. 'Cause I don't know for sure. I don't know how effective they are in preventing the events from occurring, and what the potential incremental risk could be as far as hemorrhagic events. There's one paper from NYU. I talked about some of these hemorrhagic events, and I think it wasn't that small. It was like 2.2%, which, you know, it's 2.2% sounds low, but if 1 in 50 patient has a symptomatic hemorrhage, you know, on anticoagulation, that's in the short period of time during COVID, you know, it's not like a 2.2 rate of hemorrhage over 5 years. That's over, you know, 3 or 4 weeks. That's not insignificant. You probably should pay attention to that. So, you know, it's easier to undo an ischemic event these days than it is a hemorrhage event. You can't take away the hemorrhage, but if you identify the ischemic event, at least we have a treatment for that, that you can reverse it if you identify it quickly. So for all those reasons, I currently have equipoise. I'm not sure what to do. And I haven't seen data to say how often these late events are occurring, but I've heard anecdotes as well.
Any other questions from anyone? Well, it looks like we are on time. And Dr. Zammit, thank you so much for joining us. We appreciate it. Thank you for the presentation. I think we kind of got 2 in 1, door in, door out, and some COVID. So this was all the better.
Sure. Yeah. No. Thank you. Actually, thanks again, Amy, for letting me talk and share. I'm pretty excited about the work that everybody did on that door in, door out product, especially. So I appreciate being able to share that. Anyway, I'm interested in learning more about your group's work, and if there's anything else that I could contribute, or any feedback you have, or anything the other way around that you can offer us as we're working on our system of care. I know we'd appreciate it greatly. So thanks again for your time, everyone.
Thank you.
All right, I'll step out. Enjoy the rest of your meeting.
Thank you. Okay, so next on the agenda is Kari Moore with the Overreact campaign. Kari, are you presenting slides on this?
No, just one later in the overall, but no,
Okay.
Just a brief update. Won't take the full 15 minutes. So we are, of course, now that we have the whole group together, we have been working very hard on trying to obtain the data for the zip codes and the Louisville metro area hospitals for the time periods of Overreact that was run by Genentech. And just some background for some of the newer members. So we worked with national marketing and sales, as well as legal at Genentech, and we ran into some barriers there because national AHA has a contract with Genentech, and therefore the data cannot be shared in any way. So the initial ask was, I know, Abby, right? That's what I said. It's our city. It's our hospitals. We're not asking you to give us hospital level data. So my next question was then, well, could one of the Genentech representatives perhaps, or even the AHA representative nationally, would we have an opportunity to see the overall data, which was the Louisville market, Birmingham, I had them written down. Another place I think was in Virginia, and I can't remember the fourth one, but there were 4 cities. And the pilot data looking at pre-notification, onset of symptoms to arrival, and of course, door to needle times. Did those improve with the ads by radio, TV, et cetera? So we found ourselves in a position where we were able to get the zip code data from Genentech. So we have the zip code data, or the zip codes used for where they ran the campaign. So now we have, Amy, about a month ago, was it? We finally now have de-identified data for 2017, 18, and 19 for the hospitals in the Louisville metro area where the ads were run. Of course, with Amy leaving and with Allie, the epidemiologist at the state, who was going to be able to nicely run the data analyses for us, we have run into a bit of a snag with that. However, now that we do have the de-identified data, we will be moving forward to find an epidemiologist that can sort of run some of these analysis during the time periods pre and post. So hopefully in the next 6 months, it may take some time, some questions back and forth. We'll get Abby up to speed, as well as Bonita, because Bonita is the super user now. And of course, that was not her traditional role, knowing how to do data downloads, working with Sasha, and Amy has volunteered to sort of stay on board as needed to sort of help us navigate this. But essentially, it's now a data download, making sure the data coming out of Get With The Guidelines is valid, and being able to find the epidemiologist that can help us do the analyses. So hopefully we will begin to see some movement on this end of the year, beginning of next year, once we can move forward with it. So I apologize for the delay. I do think it's going to be interesting. And we did run into a roadblock as far as the ask, and maybe we can come back around to it again and ask again. But as far as from Genentech or AHA, would they be willing to have a representative that would share the data for it? But the last I heard, and I know we haven't seen anything come out, I think it was an internal project. I don't think it was done or intended to share, is kind of the last word that I received. So interesting, because I thought it would be nice to know, well, how did Louisville compare to Birmingham, to the other 2 cities, et cetera? And was there any difference anywhere? And if there was, maybe trying to understand what impacted that change. So we'll continue to move forward on that. I also did want to take my extra, it's not a debate, but I'll take my extra minutes that I have left over to discuss something else on the clock. But I did want to thank Amy for her outstanding leadership over the last 5 years. Truly, you stepped in, took right off, always smiling, always happy, always positive, always, helping guide all of us in the right direction in a collaborative approach. And anything that you could do to help any of us or the team, you were always front and center. And I can't tell you how wonderful it was to work with you. We thank you. And of course, all the best. And we certainly would be willing to work with you and Dr. Zammit. And I'm sure we can learn from him on door in, door out and mobile stroke units and all kinds of things. And the close proximity, I think, lends itself well to a collaborative approach there. So at the same time, we welcome Abby back to the team, also outstanding. Most of us have worked with her for many years, so we should probably not lose a beat there either. So we're excited. We thank you. And if anybody has any questions about the Overreact campaign and the data or suggestions, I think if you have anything that you would like us to add to that, now would be a good time, because we could go back and try to glean some additional maybe metrics or data points, since we had to sort of start over from scratch. Thank you.
Does anybody have any questions for Kari? And I have to say, with Abby, you guys are definitely getting an upgrade. She's taught me everything between her and Star, so I know you guys are gonna be in excellent hands. All right, last call for questions for Kari on Overreact. Okay, so next up is the Louisville EMS Stroke Systems of Care pilot with Kari, Lacey, and Kyle. Lacey, do you have any slides? Are you going to share your screen?
I don't have any. Oh, sorry guys, didn't mean to mute and unmute myself there. I don't have any slides. Do you want me to show the our presentation that we gave to? Do we want to show them the presentation that we gave to our air providers?
Yeah, I think so. Why don't you and Kyle run sort of through the highlights and where the most feedback was, if you think that's helpful.
Yeah, not a problem. Hang on just 1 second.
I know I saw Kyle earlier, but he may have had to pop off.
Yeah, I don't see him on now. I don't know if he's flying today or not.
Yeah.
Apologize for my dog.
Totally know about it.
It's been an interesting morning. We've had a lot of fire trucks and ambulances and just in general sirens, and he has to add his voice to the chorus of the siren. So it's just been so much fun. Amy, can you pull up the slides, because I had them and now I can't find them.
Give me 1 second.
Let's see, do you have a maybe?
Yeah, I have them. It won't take me but a second to get to
okay. Perfect.
Oh, that's the invite. Okay.
All right, you guys should see it.
Excuse me. All right, so just a little background, you guys. So we, through our Louisville Stroke Systems of Care group, which encompasses all of the hospitals in Louisville, we decided that we needed to take on the large vessel occlusion severity scale in the field. K-Beams has endorsed and approved the use of CSTAT in the field, but we're not seeing much use of it in Kentucky, for that matter. It's kind of hit or miss. So we decided that we wanted to start with our air services in Louisville, especially when they are going to be bringing us scene strokes to our ERs, and we wanted them to essentially add a large vessel occlusion severity scale to their work triage in the field. So obviously, when we talked about this with them, we did a little webinar with myself, Kari, Amy, and Kyle was the one who presented this to his cohorts in the air services, because we felt it was best that it came from someone who was doing the work in the field just like they are. He can speak to what he does. He can speak to, the protocols that he has with air methods, and it went over very, very well, in fact. But we found it to be important that we talk about why we needed to do this in Kentucky, because stroke is so prevalent. We did talk about SEQIP, as Kyle would mention in his presentations. Before he joined our group, he had no idea what SEQIP was. And we felt it was important that we convey to our colleagues in the air services, this is the work that we're doing at the hospital level, and we are a large group of hospitals working together to improve stroke care in Kentucky. So they understand that we have a large group behind us doing this work. So obviously we shared with them the infamous map of the United States of what it looks like for stroke deaths. And obviously we're in the dark purple in Kentucky. You know, I always tell EMS in my presentations to them, we're the kind of the belt buckle of the stroke belt. And you know, we have high prevalence rates of stroke. We have some of the highest risk factors in the country when it comes to stroke. And then obviously our death rates are among the highest. We did show them exactly, again, what SEQIP was. We talked about its establishment in 2008 and how the collaboration among hospitals has just increased over the years, and how we have hospitals contributing to get with the guidelines, and we have a stroke registry, and we're represented on all levels of care for that matter. So it's important, again, for our EMS colleagues, both ground and air, to know that we are a collaborative group in the state, and we all do have the same goal in mind. You can go to the next slide, Amy. We did a little oversight of the committee and the subcommittees with them. We shared with them the our strategic goals and map for the following years, and you can see in the highlight in red there that we obviously we want to make sure we have a collaboration with EMS and moving forward with them. So we did have approval from Chuck O'Neill, the executive assistant deputy director of Kentucky Board of EMS, to move forward with this. Obviously, CSTAT is promoted and it was approved by the board at Kentucky EMS. So he lent his support in any way that we needed it. So we went over the stroke chain of survival, obviously with them, talking about recognizing the symptoms in the field, the timely EMS response, transporting the patient to the appropriate center, and why that they end up getting, you know, the quality care in the hospital when they get to the right center first. So we, of course, we talked about pre-hospital stroke management. This was nothing new to them in terms of, you know, quick, timely responses, managing the patients appropriately, and then getting the patient to the correct hospital. Go on to the next slide, Amy. You know, again, reviewing, getting the patient to the highest level of care, quick turnaround from dispatch to when the team responds, you know, quick time on scene, and then travel time as quickly as possible to that hospital. Pre-hospital management, the big question we had for our air crews when we presented this was around blood pressure management. The question we had to them was, how often are you seeing incredibly hypertensive patients that are above that 220 parameter are you having to treat, and what do you treat with? And obviously that is when they would call medical control to find out how to proceed forward. It was very few and far between with those air providers that they said, oh yeah, we've had patients above the 220 threshold and we've had to treat. Most of them said, you know, they can get to a hospital in a timely fashion to have the providers in the emergency department treat that blood pressure. So obviously that was a big topic of conversation with our air providers when we did the webinars. We did share with them that Kentucky does have favorable protocols for EMS in place. We're one of the few states in the country. As you can see, we are in blue. In other states like Alabama, Louisiana, Washington, Maryland, it looks like Rhode Island, that little blue dot in the map. So we, I still know my geography. um, so we're very lucky in that regard. For all the things, the risk factors that we have in Kentucky in terms of stroke prevalence, at least we can move forward with making sure our EMS providers are given the proper tools to triage these patients appropriately. So we did share with them the stroke protocols that K-Beams does currently have for BLS providers and all that stuff. We did also share with them, oh, you can go actually right there. So we talked about those protocols that they have. We obviously talked about the Cincinnati Pre-Hospital Stroke Scale. Everybody does that first. And then we went into what the CSTAT is. We conveyed to them that they don't move on to the CSTAT unless they have done a Cincinnati Pre-Hospital Stroke Scale and that it's positive. We talked about the ease in the use of the CSTAT and what it does in terms of recognizing a potential large vessel occlusion. We did tell them that the CSTAT can be kind of extrapolated into the NIH stroke scale on the hospital side of things. We reiterated to them that when pre-hospital providers are trained appropriately, they are more likely to recognize and be accurate in their stroke assessment. That percentage rises from 61 to 66% to 86 to 97%. We also shared with them the pre-notification protocol that K-Beams approved a couple of years ago. This is on their website, so it's not easy to find, but we are going to try to work on that to make things more easily accessible for people out there. So the stroke severity based triage assessment, we took at K-Beams the Mission Lifeline stroke algorithm and kind of adjusted it for Kentucky. And that way, when EMS has that patient, I mean, they're not going to pull up this algorithm in the field and go, where am I going? But they know their hospitals in their areas and their capabilities, and they know that if it's a TPA patient, that patient needs to go to the appropriate hospital to get TPA first. And then if they move on and do a CSTAT and it might be an LVO, then they need to go to that level of care that can potentially take care of that patient if that's what indeed they are. We shared with them the app that helps them do the CSTAT. It's pretty simple and easy. They can put it on their phone and look, it's got the LAMS, the RACE, the CSTAT, the Cincinnati Pre-Hospital Stroke Scale, the FAST-AD, and the VANS. So they click on the CSTAT and it goes over step by step everything that they're going to be doing for that large vessel occlusion severity scale. So the importance of having a stroke system of care and integrating IV alteplase and mechanical thrombectomy capable centers into everything that we're doing, talking about the guidelines that get those patients to the appropriate center obviously is important for them to know. It's important for them to also know the door in, door out components of when you take a patient to one center and they have to go to the other, why we work so hard on getting patients out the door quickly. So obviously we're going to share that information with them so they know that how critical of a component they are in getting these patients out the door. We did also go over COVID and stroke with them. Obviously this is a moving target and everything seems to be changing week to week, but we wanted to share with them that you may have patients that either have COVID when you pick them up or have had it in the past and weeks, months later may have a stroke as a result of having COVID. Obviously, we couldn't give them much in terms of literature because it's an evolving situation, but we just wanted to stress the importance of this is a possibility. And obviously, we shared with them that in the weeks following the declaration of the pandemic, emergency response runs and visits to the ER were both down. And in Kentucky, they've actually looked at the calls for cardiac arrest and heart attack dropped significantly in those following weeks, and they're working to pull that data for stroke. They actually in Kentucky saw the biggest drop in men. They were in the ages of, it was I think 29 to 56 was the age range, and they were the least likely to call 911 to seek medical care. I mean, we've even asked them at K-beams, can we pull the information around how many people may have died at home and never had a chance to call 911 because they were afraid to go to the hospital as a result of the pandemic. So moving target on that, but we are working to try to pull that information at the K-beams level. So we shared with them reports back that from U of L, Baptist, and Norton Brownsboro. This was a case we shared that went from Hardin to Baptist in Louisville for thrombectomy. We shared a case, it was a scene stroke from the field in Kentucky to Norton Brownsboro Hospital that went for intervention. And then we shared a case that went to U of L from the field for intervention. And so we want to also share with them the data metrics that we hope to be able to pull for this pilot. Obviously, it's important that we have the run sheet for the EMS service in the chart of the patient. So our data abstractors can pull that information directly from the chart. And that way they can look at when the unit was dispatched or notified by dispatch, I should say, looking at when they arrived on scene, how long were they at the patient before they took off? Did they document the appropriate things that we're asking them to do, like last known well? Did you use a stroke screening tool? What was the outcome? Did you move on to a severity tool? Did you document that as well? And then how was the destination decision made? Is this protocol? Is this family? Is this based on your location to what's the closest hospital? And then if mechanical thrombectomy was used, or if they went to the OR, and then also what if it was a positive stroke severity scale, but it turned out to be a head bleed? We're going to let them know that too. So we also have to thank our data analysts at our hospitals for helping us be able to pull this pilot together in terms of pulling the data for these air crews. So keep in mind that as a part of all of this, we have asked, when I say we, so Norton and U of L have trained people in the ER to look at what CSTAT is. The residents at U of L are actually doing the CSTAT, and my nurses at Brownsboro are looking at this as a part of the handoff information. So when an air service comes in and says, here's the report, this is it, it's a potential stroke, and we did a CSTAT and it was a score of 4. My nurse is going to take that information, pop it into the chart, and when they do their NIH stroke scale, since they know what the CSTAT is, they know they're going to be looking at things like eye deviation, level of consciousness, and arm drift when they're doing that NIH stroke scale. So the pilot started October 1st. It will run through the end of the year. We are hoping to have cooperative weather, just like it is today, where it's sunny and flyable, and we don't have, Mother Nature preventing our flight crews from bringing us patients. We hope to be able to start pulling data in February-ish, because we know we have that lag of turnaround time. So once we all have that data to start pulling and compiling, we then will turn that information over to the air crews. Obviously, they get the feedback. If they bring a patient to Norton, they get that feedback from me on what happened to the patient. But we're going to be pulling more information in regards to this pilot. It is our goal, after we see how this goes with air, we want to be able to roll this out to ground EMS in the Louisville area as well. We're hoping that when these air services pick up a patient in the field, that they might do that CSTAT at handoff with the ground crew, and the ground crew looks at them and goes, what are you doing? Like, should we be doing that? And that would be excellent if that's how this kind of rolls into a new phase. But we wanted to start with air first because they tend to be the most consistent with lack of turnover for better words, compared to ground. And we know that when they show up at one of our hospitals with a scene stroke, our nurses and doctors, it gets their attention, and they, tend to go, okay, like, we're dealing with something pretty serious here. So more to come on how this pilot rolls itself out, and how it goes, because we're 8 days in, essentially. So, it could be a raging success, or, like I said, Mother Nature could just really put a damper on flight crews doing their thing in the coming months. So, do you all have any questions for us in regards to this pilot and what we're doing, or is there anything more you would like to know?
Any questions, guys?
I was going to say, this is Kari, something that I thought was a couple of points I just wanted to make sure that everybody was aware of. So the severity scale use of CSTAT, great feedback from the leaders of the air services as well as the staff. We also, if they already use a different scale in different areas of the state or whatnot, we're not asking them to change. We're not saying, okay, well, if you use LAMS or you use something else, please, change what you're using and use CSTAT. We just simply ask them to change the terminology and call it an LVO positive scale. So I just want to make sure that, so if these crews are flying in all different directions and not taking patients specifically to the Louisville metro area, we did not ask them to change any type of severity scale that they're currently doing. The other thing I would note is most of them, and they were super excited about that app. Matter of fact, they were downloading it as it was being shown to them. Some of them had even commented on it. So if this is something that you have not incorporated into your outreach, I don't know that they're aware of this simple, and again, it's easy to use and it's applicable to more than the one scale. So you might share that that's available. And then Lacey, one of the most exciting things I thought that came out of the end of it with the leadership from PHI, and I know you're more aware of the whole thing than I am, the invitation to speak.
Yes.
Or if you would like to talk about that. I thought that was really exciting.
So we met with the leadership from PHI recently, and they, think this is just a really great idea, and they invited us to speak at the leadership for the Kentucky Air Providers coming up hopefully in January. They've already had to move the meeting because of the pandemic. They're hoping they don't have to again. But they want to make sure that everybody that comes to that meeting, because it's very well attended by the people within the air medical community, they want to make sure that they know about this and that everybody is doing it, which I think is just a great idea, because it just shows that they're willing to work with us, and they want to make sure that everybody's doing their part in providing the appropriate care for our patients, which I love, because I mean, with just working with EMS on a regular basis over the years, how difficult it can be to get them to buy into things sometimes. And this just, their willingness to want to help is really awesome and exciting. And the invitation to that meeting was just kind of like the topping of this Sunday. It was just very nice. So.
And they did also offer, I think moving forward, as Lacey mentioned, phase 2 will be incorporating the ground crews in the Louisville metro area, and especially in the rural, I think, like for all 3 of our hospital systems, we all have hospitals that we work with in the system, out of the system, that do transfers in. And so as the air staff does a lot of the ground EMS education, it wasn't explicitly said, but it was sort of I think there's opportunity to collaborate with the hospitals, with the air, to also extend when you can't get into ground crews or you're limited in numbers because of the runs, the only 2 trucks, only 2 crews or whatever, that them also carrying forward the messaging. I sort of heard, did you feel the same way, Lacey? They many of them were offering to take the message forward and also educate on what we're trying to do.
Yeah, I got the same impression because the conversation led to, they felt like there were some ground crews that might be overreacting to these patients because they're limited on their own resources in the ground. So they felt like they needed to hand that patient off to someone to get them to the appropriate center. And, you know, that it's not necessarily a bad thing, because sometimes those patients, they might need to be at that higher level of care and not their small community hospital, because they realize if we take them to the hospital in our county, they're going to have to be transferred out anyways. And, you know, and their willingness to want to take this message and do their own education was reassuring, which I appreciate, because we can't unfortunately reach everyone all at once. And if we have partners in this to their willingness to provide the education, that's always beneficial.
All right, everybody, any other questions? If not, we'll take a 15-minute break. I don't think we have anything else, Lacey. Just to let you guys know, if you haven't followed in the chat box, I've sent Abby all the presentations that everyone has sent to me. I will also get the presentation from Dr. Zammit. It shouldn't be too big of a deal. And then give Abby until like next week just to get everything together. We also recorded his presentation and I forgot to hit the stop button. So Lacey's presentation got recorded too. So we'll do these in blocks and you'll get that information as well.
I think it's actually still recording, Amy.
It is. And I'm like looking for the stop button.